Welcome to Peripheral Arterial Tonometry is not an oximeter, the real science and application of peripheral arterial tone signal, a webinar produced by Sleep Review and sponsored by Zoe Itamar. I am Sri Roy, Chief Editor of Sleep Review. I extend a warm welcome to the hundreds of healthcare professionals in our audience today, and a shout out to BRPT credential holders who are watching the event live on June 26, 2025. If you watch for at least 50 minutes, we'll send you a certificate by the end of the month that is good for 1 CSTE credit. Everyone in attendance will get a link to the recorded event by the end of the week. The recorded event is not eligible for CSTEs. Now I am thrilled to introduce today's presenter. Alan R. Schwartz, MD, is a long-standing investigator on mechanisms of upper airway obstruction during sleep and sedation, and has established physiologic predictors of therapeutic success with PAP alternatives. In seminal work, he has played a pivotal role in the development of neurostimulation therapies for sleep apnea. Dr. Schwartz spent over 30 years at Johns Hopkins University building the sleep medicine programs. A more thorough biography of Dr. Schwartz is available in the handout section of your screen, as well as a complete list of his conflicts of interest. Welcome, Dr. Schwartz.
Thank you so much, Sri, and it's good to speak with everybody. Good afternoon or morning, depending on what time zone you're in. The title is shown here, and we will be talking about peripheral arterial tonometry, otherwise known as the PAT signal, and distinguishing it from conventional oximetry and other monitoring techniques. You mentioned my conflict of interest. The one of relevance here really is that I am compensated for educational webinars such as this by Itamar Medical. Learning objectives today to examine and distinguish the PAT-based home sleep apnea test technologies, provide a structured approach for reading these reports and recordings, and then summarize simple steps for verifying and editing automated results. The outline really consists of three major topics. Really, the first is to look at the technology. The second is to dive into the report and in snapshot form, the recordings themselves to verify hypnogram, apnea detection, and even cardiac arrhythmias. And then finally is to draw some high-level conclusions. Let's look at the technologies themselves. Well, there are a lot of technologies that profess to be PAT-based home testing methods or technologies. Probably one of the best established, the longest established and best validated is the WatchPat device, which was FDA approved in 2005. It consists of three components that we'll review in a moment. There are several different features or characteristics of these technologies that are worth focusing on as you evaluate any sort of home testing technology. First, the kind of signal that is used as the backbone of the device for sleep and breathing detection. In the case of the WatchPat, it is the peripheral arterial tonometry signal. This signal is used to generate a hypnogram to detect RDI and AHI, sleep disorder breathing episodes, to distinguish between obstructive and central or chain stroke breathing. And in addition to that, additional features include the monitoring of body position. Well, as we look across the spectrum, there are other finger-based or pulse-based signals, which are incorporated into other devices. There are the ring devices that either clip to the end of the finger or around the finger itself. These are not PAT per se, but really are teed off the oximetry signal. That's very distinct, as we'll see in a moment. And it's because of the particular dynamics or technology of oximetry. Artificial intelligence techniques are used to extract the PAT-based signal to generate a hypnogram. But these devices, by and large, do not distinguish between AHI and RDI. They don't distinguish necessarily between obstructive and central events. And because they're finger-based, they can't tell you about positional sleep apnea. Another technology worn on the chest and the limb really is called the sleep technology. Both of these and the ring-based technologies are relatively recently approved by FDA. As a result, not as well validated as the WatchPat PAT technology. It too is oximetry-based. It generates a hypnogram generates some sleep disorder breathing indices and distinguishes between obstructive and central, and does monitor the body position. But once again, it's distinct from WatchPat in that it's oximetry rather than PAT-based, as we'll come to see. And then finally, over the past few years, the SomnoFit, a patch worn on the forehead, is once again oximetry-based. They get a simple derivation of the EEG leads to generate a hypnogram, but it too does not detect RERAs per se, only obvious apneas or hypopneas. It doesn't distinguish between obstructive and central, and it can't monitor the body position. Well, what is it that's unique about the PAT-based technologies, and how do they differ from oximetry? The WatchPat device is shown here in the upper left-hand corner. It is really equipped with 3 types of sensors, all embedded within this firm jacket. The SpO2 signal, the oximetry signal, shoots 2 distinct wavelengths of light, where you see on the y-axis the absorbance, and you see the x-axis the distinct wavelengths that are used to generate oximetry or SpO2. These wavelengths are actually passed through the nail bed in the vertical direction shown here and sensed on the other side of the finger. The reason for 2 wavelengths has to do with the fact that these individual wavelengths are used to actually pick up the signal of oxygenated and deoxygenated hemoglobin. And those 2 signals are really designed to measure pulse oximetry. In contrast, the PAT signal is generated by a distinct wavelength at 805 nanometers. That wavelength is not shot through the nail bed vertically, but rather horizontally across the finger. And it is literally the signal that is used to generate the pulse volume with each heartbeat. And because it is not influenced by oxygenated or deoxygenated hemoglobin, it's a unique wavelength that is not sensitive to the state of oxyhemoglobin saturation, but rather reflects directly the pulse volume for each individual heartbeat. And we see that here, where the oximetry signals vary in their amplitude, as shown here on the right-hand side. The amplitude of the signal varies at the distinct oximetry signals. It varies depending on whether the hemoglobin is oxygenated or deoxygenated. And as a result, it is not a pure measure of the pulse volume. Instead, the PAT signal, because it is uniquely focused on this one wavelength, it is only influenced by the pulse volume with each heartbeat and not influenced by the state of oxyhemoglobin saturation. The PAT signal, as incorporated by the WatchPat technology, provides us a high-fidelity peripheral arterial tonometry signal. And that signal is actually an index of vascular tone. It provides us a pulse volume, and it is actually indicative of the beat-to-beat changes in peripheral arterial volume. Now, that pulse volume signal is actually regulated by another component of the PAT technology, and that is a uniform pressure field around the finger itself. This is a field that actually compresses slightly the arterioles of the finger, and as a result, it negates or nullifies other sources of artifacts, such as mechanical movement and venous pulsations. By compressing gently on the finger itself, it really effectively looks at the pulsatile waveform and extracts the pure arterial pulse. As a result, the sensitivity of that PAT signal increases, and the signal to noise ratio is ideal, is much increased compared to regular pulse plethysmography that is provided by the oximetry signals themselves. And so PAT technology really combines isosbestos photoplethysmography, the unique wavelength, plus the uniform pressure field that increases the signal to noise ratio on the pulse volume signal itself. The reason this is so important really has to do with the fact that that pulse volume is used to generate a hypnogram and to generate the detection algorithms for respiratory events. The watch pad itself consists of three components. There are 3 points of contact. The chest signal is generated from the upper manubrium, and it's used to generate the snoring, body position, and chest effort or respiratory effort or chest movement signals. The wristwatch itself is invested with an actigraphy unit, and that's used to help distinguish between states of sleep and wakefulness. And then finally, as mentioned, the backbone of the device is the finger probe that really is designed to measure and monitor the pulse oximetry, but separately, the PAT technology is used to extract both the amplitude and the heart rate from this signal based on amplitude and heart rate characteristics shown here in the lower right-hand corner from the beat-to-beat pulsatile volume. And the reason that PAT signal is so important is it really detects surges of sympathetic activity. The form factor of the watch pad itself is unique. It provides an accurate, compact, and unobtrusive, yet simple way to apply for home sleep apnea testing. And that accounts for the low failure rates in clinical operations. Let's look now at the report and the recording. And the mantra for this section of the time we spend together is trust but verify. There's a high level of automation where the scores are generated automatically, but you're empowered to open up the black box and actually examine both the report and the signals, the recording itself, to verify the accuracy in determining the hypnogram, respiratory event detection, and as we'll see, even cardiac arrhythmias. Well, how do we do that? Well, the automated WatchPat report really consists of several blocks of information. Those blocks of information are summarized at the top of this page in tabular form and at the bottom of this page in graphic display. The top really summarizes basic outlines of the sleep test, namely the study times, the total sleep time, and the percentage of time in REM sleep. We're also given indicators of respiratory indices, and these indices are summarized with traditional RDI and AHI and ODI statistics carved out for REM, non-REM, and all-night statistics across all sleep stages. We're also given a central AHI index, central respiratory events, and the percentage of time of sleep time spent in Cheyne-Stokes respiration. We're given a host of oximetry statistics shown here in the green box. Those consist of the mean desaturations or naders, the percentage of time spent at relative desaturations of 4 to 9% or greater. The T90, T88, T85 statistics are then provided, and we're given some basic pulse rate statistics. And then finally, and really this is the guts or the backbone of the report, it's the graphic display. It's our starting point that really summarizes the physiology with respect to a number of the signals: snore, body position, oximetry, heart rate, and the derived hypnogram and respiratory events that are automatically detected. And our forage into the WatchPat report really starts with inferences that are generated primarily from this compressed graphic display. The bottom line here is that the WatchPat technology lends itself to generating an automated report. It's a report that saves time, affords readily scalable operational efficiencies. And the report itself is eminently readable, and it's one that really serves as our primary contact point that really directs our efforts to verifying or editing the automated scoring to generate a report that is one that is not only useful, but one in which you have a high degree of confidence in the accuracy of the report. Now, why is this, and why is the PAT signal such an important signal for generating both hypnograms and for generating or detecting respiratory events? And it really has to do with the fact that the PAT signal on the finger is hardwired into the autonomic nervous system. And as such, it is used to detect the state of vasodilation or vasoconstriction. And when the arterioles of the finger vasoconstrict, we know there has been a surge of sympathetic activity. It's that increase in sympathetic activity or an adrenaline surge that causes the vessels in the fingers to vasoconstrict. And we detect that vasoconstriction as a reduction in the PAT amplitude, shown here at the bottom of this panel. When there has been increased sympathetic drive, the amplitude of this signal goes down. And the amplitude goes down as a function of sleep-wake state, and it goes down transiently with microarousals from respiratory events. And it's by virtue of that fact that we're really able to do a lot with this signal that really allows us to generate a hypnogram and detect respiratory events. Now, how do we do that? How do we generate the hypnogram in large part from the PAT signal itself? We'll illustrate this in a 1-hour window from a watch-PAT recording. Shown here in the middle and lower panes here is the raw PAT signal that is compressed, the derived PAT signal, and finally the instantaneous pulse rate or heart rate. And we'll divide this 1-hour recording example into roughly 20-minute equal panels, A, B, and C. And you can see that the PAT and the derived PAT signal in the middle panel, B, overall goes down. That's this envelope of the PAT signal that goes down relative to the adjacent panels A and C. That decrease in PAT amplitude is shown here. It reflects intense vasoconstriction in the finger. And that vasoconstriction, the drop in PAT amplitude, is reflective of the fact that there has been an increase in sympathetic activity. The arterioles of the finger have vasoconstricted. Well, there are only two states of sleep and wakefulness that lead to vasoconstriction. One is wakefulness, and the other is REM sleep. Another feature of REM sleep is the fact that there's increased variability in both the PAT signal and in the pulse rate, the lowest panel here, where you can see the variability in the pulse goes up and becomes random and chaotic. The erratic nature of the pulse rate in panel B stands in contrast to a relatively steady signal and pulse rate in panels A and C. Well, it's the fact, by virtue of the fact that the PAT amplitude goes down and these signals become much more chaotic and erratic in panel B, that tells us that this patient likely in panel B is in REM sleep. Well, how do we know it's REM and not wakefulness? By virtue of the fact that the actigraphy signal is relatively quiescent for the majority of panel B. And that really puts us in REM sleep, except for the very end of REM sleep where the patient awakens and arouses. And it's that short period of movement that allows us to designate the remainder of panel B as an awakening, a period of wake, rather than REM sleep. In contrast, the adjacent or flanking panels A and C are non-REM sleep, and that's by virtue of the fact that there's evidence of vasodilation in non-REM sleep in these two panels, and the variability is not chaotic or erratic, but rather regular. As we see this non-REM segment here, we see regularity in the variability, and we see that the pulse rate is relatively steady in both panels A and C. And so it's easy to visually verify the hypnogram. You can pluck out visually the REM cycles, the REM periods, and you can do that, grossly speaking, in a few clicks of the mouse as you look through the recording, but you can also do that visually from the graphs themselves that appear on the report. Let's take an example of that, where the graphs tell the story as to what it gives us a rough plausibility check on the hypnogram. On these graphs, this is an all-night view in which we're representing the snore signal in orange, the body position, the oximetry then here in the black signal, the red signal is the pulse rate, and the PAT signal, the envelope of that raw PAT that we saw in the last slide. Well, we can see that over the course of the night, the PAT signal decreases in amplitude. It does it here for a discrete period of time, and roughly every 90 to 120 minutes, we see another discrete episode of vasoconstriction or decreases in the PAT signal here in the middle of the night, down here, 3/4 of the way, and then finally toward the end of the night here. Well, it's obvious that these are periods of intense vasoconstriction or increases in sympathetic activity that occur during periods of quiet sleep when the patient is not moving around. And it's really because of that fact, that we can confidently say that the patient is likely to be in REM sleep. And we're seeing the same normal cadence of REM sleep with a variability or the appearance of REM sleep occurring every 1.5 to 2 hours. This visual cross-check is associated with, when we look and uncover the automated hypnogram, we see that the REM sleep periods in the automated hypnogram, the red bars here, line up pretty much one for one with the periods of increased sympathetic activity or PAT amplitude attenuation. Oftentimes also associated with evidence of increased sympathetic activity as the heart rate goes up a teeny bit during REM sleep, again attesting to the fact that sympathetic drive to the heart as well as to the peripheral arteries has increased. This is an easy plausibility check where you can visually on the hypnogram, on the graphic display, visually verify the plausibility of the REM periods that WatchPat automatically assigns to the hypnogram. And by default, the adjacent or surrounding periods are largely non-REM sleep over the course of the night. And you see that here with stages of non-REM sleep represented between the discrete or distinct REM cycles. Well, we can summarize what we've learned from the PAT-based hypnogram in that changes in PAT amplitude and variability allow us both visually and in an automated fashion allow the WatchPat device to readily distinguish between non-REM and bouts of REM sleep. And the automated hypnogram is easy to verify, to do a quick plausibility check, and as you'll see, also easy to edit visually if you so desire by diving into the recording itself. Our ability to discriminate REM from non-REM sleep allows us to really pick up and gives us a real leg up in sleep apnea detection. And it occurs really in two fashions, in two types of classic examples where sleep apnea varies either as a function of sleep stage or body position. Now, this is an obvious example where the REM periods that are detected automatically by PAT, by the WatchPat device, shown here in these rectangles, these vertical rectangles. These REM periods are associated with periods of intense intermittent hypoxia. And you see that here in the black signal. Each and every one of these REM periods is associated with intense intermittent hypoxia or apneic activity. Well, this is an absolutely characteristic pattern of a patient who has predominantly REM-related sleep apnea, but the sleep apnea itself is relatively low or non-existent in the adjacent periods of non-REM sleep, where you see that the oximetry signal is relatively steady. The intermittent hypoxia goes away. And so even though this patient is snoring consistently and heroically through the night, shown here with the decibel meter here and the orange signal, Even though the patient snores consistently throughout the night, it's really the REM periods that bring out the apneic activity. And you would expect to find that the REM AHI and RDI and ODI are very high, but the non-REM AHI, RDI, and ODI are very low. And that's by virtue of the fact that in many patients, REM sleep is associated with a loss of upper airway dilator muscle activity. And it's that loss of activity that leads to greater degrees of upper airway collapse in many patients that really is restricted or confined to the REM sleep periods that you see here. In contrast, non-REM sleep, dilator activity doesn't decline quite so much, and that may, in many individuals, stabilize airway patency. We see a similar pattern here where rather than REM-related apneic activity, we can see that the apneic activity is confined to the supine position. Shown here, the supine sleep is shown in this black line here that stretches out over the course of the night. And there's only one period here, a block of about an hour or two, where the patient is on the side position rather than supine. And it's when that patient is in the side position that you can see that the apneic activity in the oximetry trace is relatively absent. And WatchPat assigns fairly few sleep disorder breathing events for the side position. In contrast, the supine position is characterized by intense intermittent hypoxia and even increased variability in the pulse rate. All of this really goes to say that the patient is having apneic episodes and rousing repeatedly, leading to these desaturations and arousals. The arousals characterized by periodic increases in heart rate that terminate the apneas themselves. And WatchPat reflects that with the blue confluent apneic episodes or respiratory events that really exist one after the other over the course of the supine sleep. It's really on that basis, increased airway collapsibility where gravitational forces favor upper airway obstruction in supine more than side position. It's on that basis that you can easily sort of visually detect positional sleep apnea. And it's really our ability to distinguish REM from non-REM periods that allows us to say with confidence that this is a patient who has positional sleep apnea, not REM-related sleep apnea. It's not related to the distinct REM periods, but rather the periods of supine sleep where there's intermittent hypoxia here. Well, this is globally one of the broad distinctions that you can make visually and confirm in the tabular data on the report itself. As we look in greater detail as to the presence of sleep disorder breathing episodes or respiratory events, we should dive in a little bit more into the methods for WatchPat's detection algorithms for detecting the respiratory events. Apneic events are generally terminated by bouts of sympathetic arousals, brief increases in sympathetic activity that accompany the microarousals. And that's shown here where an arousal is detected from two signals provided by the PAT signal itself. One is the arousal is associated with a reduction in an increase in sympathetic outflow, and that increase in outflow is shown here in the PAT signal as the PAT arterial blood volume goes down. As those arteries vasoconstrict, blood volume goes down, we see a marked attenuation of the arterial volume signal in the PAT signal when the patient has a microarousal from a respiratory event. But that increase in sympathetic activity is also reflected by an increase in the heart rate at exactly the same time. And it's the confluence, the overlap of the reduction in PAT amplitude here and the increase in heart rate that tells us the patient has had a microarousal from sleep. We'll call that microarousal, these signal changes, the reciprocal pattern, because it really is our indicator that the patient has had a microarousal from sleep. characterized by increased sympathetic activity that drives the heart rate up and the PAT amplitude down. And we see that really in patients with moderate to severe sleep apnea, the WatchPat device is designed to first and foremost detect these reciprocal patterns that occur periodically, the drop in PAT amplitude, the rise in the pulse rate. And you can see a half a dozen of them over a several minute period in a patient with pretty bad sleep apnea. Those microarousals are the starting point for detecting respiratory events. But the events are only respiratory if the microarousals themselves are accompanied by some other disturbance in the respiratory signals. Now, in this case, with this example, you see distinct desaturations. Presence of a reciprocal pattern in desat constitutes a respiratory event. The events themselves are automatically marked in the recording. But even if the patient doesn't desaturate quite markedly, there are changes in the snore and the respiratory effort signal that can help demarcate respiratory events and distinguish these respiratory events from non-respiratory microarousals. It's on that basis that WatchPat really can count up and tag the respiratory events, but goes one step further. Not only tags the respiratory events, but also by virtue of the fact that we generate a hypnogram, those respiratory events are actually divided by the total and non-REM and the REM sleep times to generate what would ordinarily be called an accurate AHI, literally the number of respiratory events divided by the individual sleep times, non-REM, REM, and total sleep time. It is by virtue of that fact that we can really generate accurate indices for AHI in REM, non-REM, and total sleep time. It's with this background that we can propound a structured approach to reading the PAT-based sleep studies. It starts with the computer-generated report, and as we've already seen, we can confirm from the report itself, and specifically the graphic display, we can generate our own impressions or inferences about the sleep architecture by distinguishing visually periods of non-REM from REM sleep, and we can get an understanding or a feel for the sleep disorder breathing patterns, and specifically whether the patient has mild, moderate, or severe sleep apnea based on our visual analysis of the PAT and the heart rate signals that you see and the oximetry signals that you see on the graphic display. We've been able to visually recognize obvious instances of positional sleep apnea or REM-related sleep apnea as well. But when our visual impressions, we're able to take the next step, and that is to say, to confirm whether our visual impressions from the graphs themselves are actually confirmed by the tabular data represented at the top of this page. When they are, we're home free. But if we come up with any discrepancies between our own inferences and the tabular data in the report, we can target those specific areas in the recording itself, where we look at the recording with greater scrutiny and target specific areas that we want to look at in greater detail. When we do so, it's pretty easy, as we can look at the raw PAT signals shown here. We're given in the upper panel the full night view, which is really showing us, if you will, the hypnogram, the automated detection of the PAT respiratory events, and then we explode out in a 5-minute or 10-minute segment, the wrist actigraphy, the body position, chest movement, snoring, oxygenation, the PAT amplitude signal, raw and amplitude, the heart rate, and once again, the sleep stage. And you can see that there's manual editing provided by these events. There are events that WatchPat automatically tags, characterized by reciprocal patterns and desaturations in this case. But there's one event that WatchPat missed, but nonetheless, we can see visually the reciprocal pattern and the desaturation. We've added that event manually. And the addition of that event is shown here, where the white background on that manually generated score tag shows that we've added that event manually to the recording itself. We can go a step further and confirm whether the events are obstructive or central in nature. In this case, obstructive events are actually characterized by a period of airway obstruction, and when the airway occludes, the snore signal goes silent. There's no air movement despite vigorous respiratory efforts. We see those vigorous respiratory efforts during the apnea phase by virtue of the fact that the patient is breathing in breath to breath harder and harder as the patient becomes progressively asphyxic. But this obstructive apnea ends with an abrupt microarousal from sleep. We see the microarousal as the reciprocal pattern here. And it's exactly at that point that the patient issues a resuscitative snort. You see the snort in the snore signal, and there's an abrupt decrease in the respiratory effort now that the airway has opened up. And because of the fact that the airway opens suddenly, there's a resumption of ventilation that occurs instantaneously. We see that the resaturation is much, much steeper than the preceding desaturation that resulted from the apneic episode. Well, it's this asymmetry that allows us to detect not just the respiratory events, but it allows us to classify these events as primarily obstructive in nature. We also know that there are hypopneas and reras in which the airway is not slammed shut as it is in the case of an obstructive apnea. We can detect those hypopneas and reras very easily because we see the same kind of asymmetry that we saw with the apneic episodes. The asymmetry results from the fact that airway obstruction ends abruptly when the patient has a microarousal. The upper airway muscles get a charge of CNS activity and the airway opens up abruptly. How do we know the airway opens? Well, it's the fact that the snore signal goes away abruptly. And here we see at the microarousal, we can see that leading up to that microarousal, the patient is generating some airflow, but the airway remains partially obstructed in the case of hypopneas and reras. Increasing crescendo increases in snore activity are matched by increases in respiratory effort. In both instances, the hypopnea and the rera, the effort goes up and the snoring increases right up to the point the patient arouses from these events. And it's at the microarousal that the snoring goes away as the airway opens up completely and the effort goes down. And you see that in both instances of hypopneas and reras. But because there is at least some ventilation during the events themselves, oftentimes the desaturations are much less pronounced as compared to complete apneas, complete upper airway obstruction. And the main difference between the hypopnea and the rera is really whether or not the desaturation itself exceeds either the 3 or the 4% threshold level. Well, these are the different kinds of obstructive events, and those obstructive events really are characterized by periods of increasing effort during the events, changes in the snore pattern that occur exactly at the microarousal, and they're usually or often accompanied by variable degrees of desaturation. Each one of these types of obstructive events end up terminating with the reciprocal pattern or the microarousal from sleep. Well, we can summarize the features of obstructive events on the report. We've seen that they can come out in force in REM compared to non-REM sleep, and they're often associated with a lot of snoring. And the tongue flops back into the back of the throat more readily when patients are in the supine compared to side position. But we can confirm the obstructive nature of these events in the recordings themselves. We see the augmenting respiratory effort leading up to the microarousal, and the asymmetry, particularly in the oxygen saturation slopes, where the patients reset during the microarousal much more quickly than the preceding DSATs. And it's this asymmetry with respect to every respiratory signal that tells us that we're likely dealing with an obstructive, not a central event. Now, we'll contrast these features to those that we see in a patient with primarily central sleep apnea and Cheyne-Stokes respiration. Cheyne-Stokes breathing improves during REM sleep. And we see the REM periods here in the vertical rectangles, where what we see here is the periods of intense desaturations go away or get a lot less during the REM periods. In fact, the apnea gets better in REM compared to non-REM sleep. The surrounding areas of non-REM are associated with a lot of fluctuations or intermittent hypoxia here in the O2 sat signal. And in this case, there's also much, much less snoring. The lack of snoring and the improvements in sleep apneic activity during REM sleep, these two features are features that really help us visually distinguish a patient or detect a patient who has predominantly central sleep apnea and Cheyne-Stokes breathing. We can confirm all of these features on the recording itself. Shown here, a period of non-REM sleep in the middle of the night, where we see evidence of central apneas with a loss of respiratory movement, leading up to these reciprocal patterns here in the PAT amplitude and the pulse rate signal. Patients are roused, but they also have a typical waxing and waning hyperpnic phase here. Intervening hyperpnias with waxing and waning of respiratory effort, punctuated by the central apneas where the respiratory effort goes away. Another feature, though, of Cheyne-Stokes and central sleep apnea is oftentimes you see that the circulation time, the transit time for blood between the lungs and the oximeter in the finger is oftentimes prolonged. In this case, twice normal compared to a normal circ time of about 16 seconds. This circulation time is twice normal, consistent with an underlying cardiovascular or cardiac etiology to the Cheyne-Stokes breathing patterns that we see in the recording. Now, on the report itself, you've identified the central apneic index, and we've got the Cheyne-Stokes breathing percentage as a percentage of total sleep time, both of which raise a flag to the presence of some degree of central sleep apnea and Cheyne-Stokes breathing. The bottom line is that central and obstructive respiratory events are automatically scored, but they're easy to distinguish one from the other, and in fact manually visualized and edited as you see fit. Well, let's look briefly. WatchPat itself has incorporated in recent years automatic flagging and detection of cardiac arrhythmia. And that really stems from the fact that we can look at the cadence or regularity of the PAT, the pulsatile PAT signal, where not only does the PAT amplitude change, but the frequency content changes abruptly. When it does in a random fashion, we oftentimes are detecting premature beats, and that's reflected here in the PAT report. When the overall pattern of cardiac frequency, the pulsatile nature is somewhat random and chaotic on an ongoing basis over the course of the night, WatchPat will raise the flag as to suspecting the presence of bouts of atrial fibrillation. We're given the total duration, and the longest such paroxysm of potentially atrial fibrillation summarized here on the WatchPat report. And once again, you've got the opportunity to go into the recording to verify whether WatchPat has flagged these events properly by simply looking at the frequency content or the overall patterns of the PAT signal. These are flags that WatchPat raises because we know that atrial fibrillation is connected to the presence of sleep disorder breathing, where it's in recent years become imperative that we detect and intervene on sleep apnea in order to keep patients in a stable, normal sinus rhythm and prevent them from having recurrent bouts of atrial fibrillation. So we can summarize here that WatchPat automatically flags these common arrhythmias, such as premature beats and atrial fibrillation, but also gives you the opportunity visually to confirm and call out the presence of these events so that the clinician who receives the report is alerted to these possibilities and might take appropriate clinical action to follow up. Well, I'd like to conclude here with the notion that the WatchPat device in particular was FDA approved in 2005, and that fact has allowed for a whole host, nearly 24 very different validation studies that in the aggregate have demonstrated that WatchPat's results are highly correlated with gold standard polysomnography, sleep apnea, and hypnogram detection schemes, in that the correlations here really have show a high degree of correlation, roughly hovering in the high 80s to low 90% out of 100%. These are very, very high degrees of correlation, which show that the WatchPat is an accurate device for detecting moderate to severe central and obstructive sleep apnea. Number of studies all showing very, very high degrees of correlation. And it's really on that basis that the AASM has allowed for home sleep apnea test devices that are either flow-based with oximetry or PAT-based with oximetry and actigraphy, either one of which are actually legitimate and considered to be standards for the field in home testing for sleep apnea, where the pretest probability of moderate to severe sleep apnea in the absence of significant comorbidities is deemed to be clinically highly likely. The summary here is that the WatchPat in particular is a well-validated instrument. It's accurate, and it's accurate for not only diagnosing, but also classifying the type of sleep apnea that exists in your particular patient. As we pull back and summarize, the structured approach for reviewing the automated scoring and the report and recording really consists of several discrete sort of steps. First is you can have a high degree of confidence whenever the automated AHI and ODI are in the moderate to severe range. It's really under these circumstances that you know that the reciprocal patterns or microarousals are substantiated by significant desaturations. And you can confirm just on the basis of the report the presence of moderate to severe obstructive sleep apnea. We've also seen that positional apnea and REM-related sleep apnea are easy to spot on the visual or graphic display, and these also can be easily sort of pulled out and flagged for the end user. And we've seen that you can suspect the presence of central versus obstructive sleep apnea. You can distinguish or classify the types and raise the plausibility of one type versus the other, just from your understanding visually of the graphic display on the automated report. You can confirm all of these features in the recording themselves, but the starting point is once again the graphs on the automated report. We've seen, secondly, that WatchPat is good for flagging and distinguishing central from obstructive sleep apnea and helps to flag common arrhythmias such as premature beats and atrial fibrillation. But we would also say that whenever there's a discrepancy, if you will, between the RDI and the AHI, or between the HI and the ODI. That's a flag that is raised by the report, but gives us the opportunity to go into the recording to see what's tweaking that patient, what's generating the microarousals or reciprocal patterns that may or may not be respiratory in nature. And it's that flexibility that really allows you not only to suspect and verify or generate a quick plausibility check on your final diagnoses, but really essentially verify with the signals in the recording itself. And if you will, edit those signals, because the editing process is important for you to verify or edit the findings in generating an accurate report. Summarize, WatchPat HSATs are generally compact and unobtrusive. They're simple to apply, and as a result, low failure rates in clinical routine. The automated report saves a lot of time, staff time, and physician time, and affords readily scalable operational efficiencies. The automated hypnogram is easy to verify visually and editable when you can dive into the recording. We can distinguish central from obstructive respiratory events. They're automatically flagged and scored, easy to recognize, to suspect visually in the graphs, and to edit manually in the case of the WatchPat, where you have the flexibility to dive into the recording. And as a result, WatchPat is a potentially powerful, well-validated, and accurate instrument for diagnosing and characterizing or flagging sleep or classifying sleep apnea in your patients. I'll stop there, and probably we've got hopefully a few minutes to take time for some questions or comments, and I'm happy to hang on for as long as the organizers would like. Thanks so much for your attention, and we'll go from there. I'll probably stop showing my screen, and we can have a dialogue or a discussion from here.
Thank you so much for explaining why peripheral arterial tonometry is not an oximeter. As he mentioned, we are beginning with the Q&A now. We're starting with questions submitted during the webinar registration process. We'd also love for you to type additional questions into the Q&A box on your screen now. First question. Very rarely, we will have PAT tests on patients that show a normal AHI. The test will show all sleep stages, including REM, and will also show some supine sleep. Then when they came in for PSG, the AHI is severe. Any guesses why the PAT test is missing the mark by that much?
Well, I think it's important to realize that you are comparing two separate nights. And so the discrepancy may be due to night-to-night variability in part. Night-to-night variability on single observation nights, whether they're in the home or the sleep lab, is known to occur and is often quite high and leads to some degree of misclassification of patients when it's based on a single night. I would say my next step, though, in sort of reconciling those differences is to look at the sleep architecture. Oftentimes, patients don't sleep well in the sleep lab. And so if the diagnosis of sleep apnea is in the sleep lab is rather severe, it may well be that this patient has a lot of transitional wake 1 or N1 wake transitions, which we know are associated oftentimes with a lot of sleep onset, sleep disordered breathing episodes, often central in nature. And so you want to look at sleep architecture and make sure that we're comparing apples to apples between the home test and the in-lab test. I would also look at other factors that may well influence the testing scenario, either in the lab or the home. May have to do with medications that are taken or not taken in either setting. It may also have to do with other circumstances that may be reflected in either sleep architecture or in the detection of sleep disorder breathing events, including the fact that the standards for detecting those respiratory events may differ between the home and the lab. Make sure that we're using the same desaturation threshold in both situations. And also make sure that if you still cannot assign or determine why there is that type of discrepancy between the two test settings, rest assured that you can dive into the recording itself with either type of test. The laboratory test, that's the PSG, the home test, the WatchPat gives you all the flexibility in the world that you can open up the black box and see what is it that is driving the presence of severe sleep apnea on the WatchPat recording that may or may not be evident in the sleep study itself. I will say that if the discrepancy between the two types of tests is related to RERAs themselves, then those RERAs in both settings, the lab PSG and the home setting, really need to be examined and scrutinized very, very carefully to make sure that the RERAs themselves are respiratory in nature. And there can be tremendous differences in the classification that really essentially beg you to look at the recordings themselves so that you can distinguish, for example, PLM from RERAs in either setting.
Excellent. Our next question is specificity and sensitivity using what AHI cutoff?
Well, we showed that a couple of slides ago, that there's been a raft of validation studies. Many of them were done some 15 years ago, 10 to 15, 20 years ago. And those validation studies were undoubtedly conducted using a 4% desaturation cutoff. Not uniformly, but certainly the 4% cutoff was the prevailing standard at that time. In more recent times, we did a validation study at Hopkins using the 3% cutoff, and found that indeed we came up with high degrees of correlation between WatchPat and simultaneously acquired polysomnograms. These were patients, several hundred patients that came into the lab. They underwent routine polysomnography, and we put a WatchPat device on them at the same time. And we found that, lo and behold, we had a high degree of correlation with both measures of sleep architecture as well as measures of respiratory sleep disorder breathing indices. We also found that when you visually overread these studies, you improve the correlation. In some instances, you improve the correlation by a modest amount. And so the visual overread process allows you to still improve at the 3% threshold. And it's really on that basis that I think we can say that because of the combination of validation studies at the 4% threshold and the more recent study at the 3% threshold, that we've really got a wealth of validation information that allows you to look at the automated results with a high degree of confidence. But also there's an approach to visually analyzing the report in a way that generates inferences that you can and should confirm in a targeted way, with the advantage of being able to open the recording itself. I'll stop there.
Excellent. One person says, we see a lot of RDI is greater than AHI. Can you go over the algorithm's detection of RERAs? Is PAT too sensitive for RERAs? Similar question for central apneas. What thresholds does the algorithm use to call a central event?
So let's unpack that. There are a lot of questions embedded. Let's first tackle the RDI greater than AHI. For me, that becomes that finding where there's a discrepancy between a high RDI and a somewhat lower AHI. That finding raises a flag. It's an important flag that I really want to emphasize. If I can, maybe I can start showing my screen once again and just go back one slide. That possibility is covered here, and I hope you're able to see the slide. It's covered here by the last major bullet point, where there's a discrepancy between the RDI being relatively high and the AHI being relatively low. These findings really indicate that both of these events are actually detected first and foremost by detecting the reciprocal pattern, the microarousals that occur and terminate either type of event. The issue is whether that reciprocal pattern is associated with some obvious perturbation in one of three respiratory signals. Those signals are the oximetry, the snore signal, and the chest movement signal as an index of respiratory effort. Now, where there is not an obvious desaturation to the threshold, to the 3 or the 4% threshold, where the desaturations are more modest, you will find that respiratory events will pile up, so-called RERAs will pile up in the RDI statistic, but will not be included in the AHI or the ODI statistic. That will generate the discrepancy that the question asks about. And now the question is, why does that occur? Well, this is a flag that really sends me right into the recording, because the respiratory events, or so-called RERAs, that WatchPat automatically detects may well be RERAs. And we know that there are populations of patients in whom RERAs are very common. Women who are premenopausal tend not to desaturate all that much. And we know that there are patients with low arousal thresholds who may not have RERAs at all, but really may have hyperaroused states such as insomnia, PTSD, fibromyalgia, etc. Sometimes we also see that heart rate variability that leads to detection of, quote, microarousals that is really related to a lot of premature beats. And all of these findings can be confirmed as you look at the recording itself. You can determine whether there's a distinct perturbation in one of those three respiratory signals, in which case they are true RERAs, or whether the perturbation that you see is really essentially the microarousals or reciprocal patterns that occur without a respiratory perturbation, in which case you may be dealing with a pattern that's more consistent with PLM, arrhythmias, or some of these other distinct states. And it's really on that basis that you should take this finding as actually a help, a flag that really sends you in the direction of the recording in order that you can provide an accurate read of the sleep study overall. The last part of the question really relates to distinguishing Cheyne-Stokes and central sleep apnea based on the automated indices. And I would say to you the following, much the same as we discussed a moment ago with respect to this discrepancy between RDI and AHI. When there's a lot of Cheyne-Stokes breathing, or there's a high central sleep apnea AHI index, then I take that also as a flag. And that's an invitation to open up the recording, not to score every epoch the way you might rifle through for a PSG recording, but really to go and look in a targeted way at snapshots, screenshots of 10 to 20 minute duration, where you can easily discern the Cheyne-Stokes and the central apnea features that we highlighted in one of the slides a moment ago. And if you can discern those features, then you can rest assured you're dealing with some component of Cheyne-Stokes or central sleep apnea. You can also discern the obstructive features, and it's really based on either symmetry, in the case of central and Cheyne-Stokes breathing, versus asymmetric signals in the case of primarily obstructive events that you can actually see and visually detect the symmetry or the asymmetry that allows you to state with confidence that the patient either has a strong underlying obstructive component or the converse, a central or change stroke component to their sleep disorder breathing episodes. Again, take these statistics on the report to be flags that send you into the recording, but they do so in a way that allows you to target the features that you are questioning the most.
We are going to continue with the Q&A for about 10 more minutes, but I want to alert those of you with the hard stop time that you're welcome to jump off now and watch the rest when you get the recording. However long you stay on, be sure to take the course evaluation, which will appear on your screen when you leave. The next question is WatchPat affected by heart pacemakers?
Yeah, so it's a great question. Pacemakers, how does that reflect in the WatchPat? The answer is in some measure it does, although WatchPat can perform quite accurately. I would first emphasize that home testing in general, and WatchPat in particular, is not dissimilar. Home testing should be conducted in people in whom you have a high suspicion of moderate to severe sleep apnea, without comorbidities, without significant either cardiovascular or cardiometabolic or pulmonary comorbidities. That said, we know that we are, in fact, doing home testing with greater frequency, and some of these patients have a pacemaker. What does the pacemaker do, and how might it influence the WatchPat's rendering of a diagnosis of sleep apnea? As mentioned, the WatchPat really detects respiratory events first and foremost by detecting the reciprocal pattern. In the case of patients with a pacemaker, if the pacemaker locks the heart rate at 60 beats per minute, your reciprocal pattern will consist only of periodic attenuations of the pad amplitude without the concomitant increases in the heart rate and the pulse. The pacemaker being the issue in which the pulse rate variability that you use to detect the reciprocal pattern may not be present. And it's really under these circumstances that I would look at those pad amplitude attenuations as your primary marker for the microarousal. But I would reinforce the fact that those respiratory events should be characterized by concomitant changes in one of those three respiratory signals. Leading up to the attenuation, you should see a change in the snore signal, a change in the chest movement signal, or a discrete change in the oximetry signal. And where you've confirmed one of these other respiratory signal perturbations, you know that the microarousal that's reflected by the pad amplitude change is confirmed to be a respiratory disturbance and not some other non-respiratory event. It's really on that basis that I would say that you can, in fact, interpret with confidence the WatchPat recording, even in a patient with pacemaker, but you want to be alerted to the fact that you should be particularly mindful and stringent in your application of the scoring standards, so that the respiratory events are characterized by a pad attenuation that is associated with a defined perturbation in one of those three respiratory signals.
Next question. Are there any patient disease or status examples of when WatchPat may not be reliable and thus not recommended for us? And a similar question, what are some contraindications for this technology?
It's a great question, and we are asked that fairly commonly. You know, there are potentially factors that might be considered to be relative contraindications, or simply flags that cause you to scrutinize the WatchPat study a little bit differently. I would take the patient with Raynaud's disease who may not have peripheral vascular control of the arterioles that is up to snuff, or the patient who may or may not be on alpha blockade. Suffice it to say that these patients have been included in the validation studies, so they don't appear to be impacting in a significant way on the validation of the WatchPat device. But nonetheless, the recordings and the reports themselves should be viewed in light of the potential that these underlying issues may in fact influence the fidelity with which WatchPat detects the microarousals from sleep, because those microarousals, or reciprocal patterns, if you will, are prominent in the detection of the respiratory events. That said, we're never looking at the microarousal itself as an isolated event, but really whether it is temporally associated with those respiratory perturbations that we spoke about a moment ago. And so even in these patients, when you have a WatchPat study, you want to simply make sure that in addition to looking at the report itself, that you go ahead and look at some snapshot views of the recording, so that the recording gives you an understanding as to whether the reciprocal pattern is associated with respiratory perturbations. That this combination of features is what is important for determining your respiratory event indices.
Please address scoring obstructive versus central events and reliability of auto scoring. I am skeptical.
Well, if you're skeptical, then that's your invitation to look at the recording. That's super important. A healthy degree of skepticism is exactly what we want to generate. In other words, consider the report to be a flag, a number of flags. We spoke about the importance of the report in detecting arrhythmias, to flag them, not to diagnose them, but to really raise the flag. And similarly, I look at those central apnea and Cheyne-Stokes indices as another type of flag that says to me, hey, are those indices exactly accurate? Well, they've been validated. So, in the overall take is that, yeah, they're accurate. But you and I know that accuracy at the level of validation studies does not mean that each and every patient is rendered an accurate diagnosis based on the automated results. And so I consider those indices and appreciate actually the questioner's skepticism. I consider those indices to be super important, because classifying or distinguishing between primarily central versus obstructive phenomena is super important and matters in terms of, management plans. And because it rises to that level of importance, it behooves us to use those indices as flags that direct us into the recording itself. Now, those flags are not isolated flags. We spoke a moment ago about the fact that when WatchPat raises the flag on Cheyne-Stokes respiration or central AHI, that those flags are often buttressed by a number of other findings on the report itself. Those findings are differences between non-REM and REM indices. And WatchPat allows you to draw that distinction by virtue of its accurate hypnogram. Oftentimes, Cheyne-Stokes and central apneas are occurring in the setting of patients who have underlying arrhythmias or chronic atrial fibrillation. It's the cardiac substrate that leads to or is involved in the pathogenesis of Cheyne-Stokes breathing patterns. And that cardiac substrate heightens our index of suspicion for Cheyne-Stokes breathing patterns. Or it's the patient on opiates or other predisposing factors that may predispose or increase susceptibility to pure central sleep apnea. And these are all relevant features that allow us, on the basis of the report itself, to raise that flag and to determine how, whether you should be more or less skeptical before you go ahead and take a deep dive into the recording itself.
Great. And this will be our last question for today's webinar. How does a physician and a scorer become credentialed to read PAT tests?
Well, in the end of the day, it's not, in my view, and this is mine, that's not anyone else's, it's not a question of formal credentialing. It's really more a question of quality improvement for all of us in the field. And we all do that by taking advantage of a variety of different educational platforms. I'll mention a few. Understanding the the pathogenesis and pathophysiology of sleep disorder breathing, by virtue of webinars such as this or conferences. We're all learning constantly about how to really scrutinize the physiology in new and improved ways. And so taking advantage of general opportunities through conferences and webinars and in-center staff updates is a vital component of any educational program. The folks at Itamar provide the PAT Academy as formal webinars, and you can view webinars like this repeatedly by accessing the recording itself and play it again and again, and play it for new staff or play it for yourselves so that you're picking up on the finer points. And then I would say that beyond that, I know the folks at Itamar provide a lot of field support, and there's direct field support to answer your specific questions. I would say to you two sort of general features that should guide your efforts at educational efforts in quality improvement. The first is really guard your skepticism. I think that's important, to maintain a healthy degree of skepticism and use that. Use your own questions, your own inferences, and your own skepticism as an opportunity for quality improvement. And second is really take advantage of it, not only by really visually generating those inferences from the patterns that you learn to recognize from the report, the graphic display, and tabular data, but make looking at the recording a routine part of your day-to-day lab activities, whether you are a staff person that is looking at the quality of the recording, or you're an interpreting physician who's signing the report. Make it doesn't have to be an extensive, time-consuming activity, but if you make it a routine practice to look at the report and generate a couple of inferences that you can confirm on the recording itself, open up the recording and you will find that you're making the connections and understanding the pathophysiology of respiratory event detection and classification much, much better by really cementing that connection between the graphs, the tabular data, and the physiology that's displayed in the signals themselves on the recording.
Well, I am feeling much more informed, and I hope all of you are too. If you'd like to reach out to our sponsor with questions, you can do so at usmarketing@zoll.com. You can also reach out to me, Sri Roy, editor of Sleep Review, at editor@sleepreviewmag.com. Thank you for joining today's webinar. Peripheral arterial tonometry is not an oximeter, the real science and application of peripheral arterial tone signal.
Thank you, Sri.